General management of poisoning. Acid-base disorders. Serum electrolytes to evaluate for metabolic acidosis should be obtained if there is any possibility of mixed ingestion or uncertain history. The diagnosis of these acid-base disorders is based on arterial blood gas, pH, PaCO2, bicarbonate, and serum electrolyte disturbances. It must be first determined as to which abnormalities are primary and which are compensatory, based on the pH. If the pH is less than 7.40, respiratory or metabolic alkalosis is primary. In the case of metabolic acidosis, it is necessary to calculate the anion gap. The anion gap is calculated as follows: Na plus K plus, HCO3 plus Cl. Normally this translates as 140, 24 plus 104, equals 12 mmol, L. Range: 12 to 16 mmol, L. If the anion gap is greater than 20 mmol, L, a metabolic acidosis is present regardless of the pH or serum bicarbonate concentration. Several poisons are associated with increased anion gap, gap acidosis, while others do not alter it, non-gap acidosis. Treatment of metabolic acidosis. The drug of choice is sodium bicarbonate. It is widely considered to be the best antidote for acidosis of almost any etiology. Add 2 to 3 ampules of 8.4% sodium hydrogen carbonate to 1 liter of 5% dextrose in water, infused intravenously over 3 to 4 hours. In pediatric patients, add 1 to 2 mEq/NaHCO3 per kilogram in 15 milliliters per kilogram 5% dextrose on 0.45% normal saline over 3 to 4 hours. Convulsions. There are several drugs and poisons which cause convulsions, e.g., amphetamines, anticholinergics, antidepressants, antihistamines, isoniazid, cocaine. Improper treatment or mismanagement can lead to status epilepticus, which is a life-threatening condition. Treatment. Administer oxygen by nasal cannula or mask. Position patient's head for optimal airway patency. Establish IV line. Begin drug therapy with benzodiazepines, either lorazepam, 0.1 mg per kilogram, at a rate of 2 mg per minute, or diazepam, 0.2 mg per kilogram, at a rate of 5 mg per minute, can be administered IV. If status persists, administer 15 to 20 mg per kilogram phenytoin at 50 mg per minute, adults, or 1 mg per kilogram per minute, children, by IV. If status still persists, administer 20 mg per kilogram phenobarbital IV at 100 mg per minute. If this measure also fails, give anesthetic doses of phenobarbital, pentobarbital, T-opentone, or halothane. In such cases, obviously, ventilatory assistance and vasopressors become mandatory. Monitor ECG, hydration, and electrolyte balance. Watch out for hypoglycemia and cerebral edema. Agitation. Several drugs and poisons are associated with increased aggression, which may sometimes progress to psychosis and violent behavior. This is especially likely if there are other predisposing factors such as existing mental disorder, hypoglycemia, hypoxia, head injury, and even anemia and vitamin deficiencies. Delirium is the term which is often used to denote such acute psychotic episodes, and is characterized by disorientation, irrational fears, hyperexcitability, hallucinations, and violence. Dementia refers to a more gradual decline in mental processes, mainly resulting in confusion and memory loss, and though it is often organic in nature due to degenerative diseases, there are some drugs which can cause this, especially on chronic exposure. Elderly patients are more vulnerable. Dementia due to drugs is usually reversible. Treatment. Delirium is managed by chlorpromazine, diazepam, or haloperidol. Caution is, however, necessary, since sedation, which is inevitable with these preparations, may sometimes result in more harm than benefit. The following table outlines measures for managing a violent patient in the casualty emergency department. Movement disorders. Exposure to several drugs and toxins can result in a wide variety of movement disorders, ranging from full-blown Parkinson's disease to isolated tremors. The most frequent culprits for Parkinsonian manifestations are phenothiazines and major tranquilizers, though there are several others which have also been implicated. Symptoms of Parkinsonism usually appear in Table 3.12. Drugs associated with agitation and psychosis during toxicity during withdrawal: amphetamines, corticosteroids, barbiturates, anticholinergics, datura, atropine, ethanol, antidepressants, digitalis, opiates, benzodiazepines, ethanol, paradoxical agitation, hallucinogens, cannabis, cocaine. Table 3.13. Tranquilization of the violent patient type of violent behavior therapeutic measure schizophrenia, or any other psychosis. Lorazepam 2 to 4 mg IM. Combined with haloperidol 5 mg IM. Extreme agitation lorazepam 2 to 4 mg IM. Every hour. Personality disorder lorazepam 1 to 2 mg orally every 1 to 2 hours, or 2 to 4 mg IM. Every 1 to 2 hours. Alcohol withdrawal chlordiazepoxide 25 to 50 mg orally, as required, or lorazepam 2 mg orally. Cocaine, amphetamine toxicity diazepam 10 mg every 8 hours orally, or IM. Phencyclidine toxicity diazepam 10 to 30 mg orally, or lorazepam 2 to 4 mg, or haloperidol 5 mg IM. The first 3 months of exposure and may be indistinguishable from idiopathic Parkinson's disease. Drug-induced myopathies may result from a direct toxic effect which may be local, e.g. injection of drug into muscle, or more diffuse when the drug is taken systemically. Repeated injections of antibiotics or drugs of addiction often lead to severe muscle fibrosis and contractures, myositis fibrosa, myositis ossificans. Ricyclic antidepressants, monoamine oxidase inhibitors, fluoxetine, lithium, buspirone, and levodopa are the principal causes of drug-induced akathisia. Dystonia usually manifests as facial grimacing or torticollis, and is mainly associated with phenothiazines, butyrophenones, metoclopramide, tricyclic antidepressants, phenytoin, and chloroquine. Chorea, which causes involuntary writhing movements of limbs, is most commonly seen with anticonvulsants, especially phenytoin, anabolic steroids, amphetamines, levodopa, and sometimes with cimetidine, ethanol, and cocaine. Phenothiazines and metoclopramide are most often the culprits in drug-induced tardive dyskinesia, which is characterized by stereotyped, slow, rhythmic movements. Myasthenic crisis, a sudden onset of severe muscular weakness, may be precipitated by aminoglycosides, polymyxin, penicillamine, tetracycline, quinidine, lignocaine, quinine, curare, succinylcholine, procainamide, and some opiates. Fasciculations are contractions of muscle fibers within an individual motor unit, and appear as twitching of affected muscles. Treatment of movement disorders. Most of the movement disorders induced by toxins or drugs are dose and duration related. Withdrawal of the incriminating agent commonly results in recovery. The usual measures undertaken in the management of the respective drug overdose, or abuse, must be instituted wherever applicable. Electrolyte disturbances. 1. Hyperkalemia. Potassium level more than 5.5 meq/L. The causes include digitalis, beta-2 antagonists, potassium-sparing diuretics, NSAIDs, fluoride, heparin, succinylcholine, and drugs producing acidosis. Manifestations include abdominal pain, diarrhea, myalgia, and weakness. ECG changes are important: tall, peaked T waves, ST segment depression, prolonged PR interval, and QRS prolongation. In severe cases there is ventricular fibrillation. Treatment: glucose, insulin infusion, sodium bicarbonate, and calcium gluconate. Hemodialysis and exchange resins may be required. 2. Hypokalemia. Potassium level less than 3.5 meq/L. The causes include beta-2 agonists, theophylline, insulin, chloroquine, caffeine, dextrose, loop diuretics, thiazide diuretics, oral hypoglycemics, salicylates, sympathomimetics, drug-induced gastroenteritis, and metabolic acidosis. Manifestations include muscle weakness, paralytic ileus, and ECG changes: flat or inverted T waves, prominent U waves, ST segment depression. In severe cases there is a V block and ventricular fibrillation. Treatment: oral or IV potassium. 3. Hypernatremia. Sodium level more than 150 meq/L. The causes include colchicine, lithium, propoxyphene, rifampicin, phenytoin, alcohol, mannitol, sorbitol, sodium salts, excessive water loss, IV saline solutions, and saltemetics. Treatment: water restriction with or without loop diuretics. 4. Hyponatremia. Sodium level less than 130 meq/L. The causes include carbamazepine, chlorpropamide, NSAIDs, amitriptyline, biguanides, sulfonylureas, captopril and other ACE inhibitors, lithium, imipramine, oxytocin, and excessive water intake. Treatment: hypertonic saline. 5. Hypocalcemia. Calcium level less than 4 meq/L. The causes include hydrogen fluoride, oxalates, aminoglycosides, ethanol, phenobarbital, phenytoin, theophylline, and ethylene glycol. Treatment: calcium gluconate IV, 10% solution, 10 ml at a time, slowly. Thank you.